Hi all of you, welcome back to the lectures. Now in this particular session, I'm going to teach you about the major differences, how to differentiate between blowout and blow-in fracture, because it's very important at this particular stage as the questions are getting more and more complicated, more and more clinical level questions are coming. So you have to very clearly differentiate between, or you have to very clearly understand between what is the exact difference between blowout and blow-in fractures. Okay, so I'll give you the concept rather than simply giving some features. I'll give you the concept. Okay, and my major purpose is, again, let me be very clear, the differentiation. Okay, the differentiation between the blowout and blow-in fracture, because I see that most students don't understand what exactly is blow-in fracture. Okay, we have already discussed in detail about blowout fracture. Whatever is important, I'll discuss it here, or whatever is required regarding blowout fracture, I'll discuss it here. Otherwise, we have another lecture regarding the blowout fracture. Okay, so it's very, very important to understand certain things. Okay, now if you just see the blowout fracture, I'll show you the images. Okay, for sure. But if you see the blowout fracture, it can be in the anterior section and the posterior section. Now it's very important to understand what is anterior and what is posterior with relation to orbit. Blow-in and blowout fracture definitely related to your anterior posterior section, but I'll tell you how it is. Okay, so if you see your anterior section, it talks about the orbital rim. Okay, orbital rim, and I'll explain to you each and every part of it, what it means. It's image, but just first understand. Also, so orbital rim is the anterior part, you can palpate it, isn't it? Posterior section goes behind the orbital rim. So four parts are there, you know, one is roof, okay? Then you have got the floor out there, okay? The roof, floor, okay? The medial wall, and definitely understandably the lateral wall. So if you come to the image out here, this is the orbital rim, okay? I'll zoom it in a little bit more. This is the orbital rim. Okay, this is the orbital rim, and if you go inside, so that's the anterior fracture. Okay, now please note, if orbital rim is involved, this is where the difference comes. If the orbital rim is involved, it is always a blow-in fracture, because in blowout, I'll come to more details of this. Okay, don't worry, but in blowout, orbital rim is not involved. Please note. Okay, so now, though there is a slight differences, I'll come to that. Okay, now we said this is the medial wall. Okay, then you've got here on the lateral wall. Okay, then okay, I'm not discussing about the orbital anatomy here. You can see, but wherever necessary, I'll come to that. Okay, at a later stage, the incidence of fracture, I'll come to a little bit of differentiating the ethmoidal bone, sphenoidal bone and all. But now I just want to describe to you the basic, very basic details. Then you have got the floor, okay, and the roof. One more thing, just to add here. The blow-in fracture involves a roof. Okay, so it involves, the blow-in fracture means roof and the rim will be involved. Roof and rim will be involved. Now, if in orbital blowout fracture, okay, there is, you have to understand the direction of force and I will come to that, but before that, just understand the very basic concept. If roof and the rim is not involved, it is not a blow-in fracture. It could most probably a blowout fracture. Okay, just understand this. I'll come to more details of this. Okay, so let us now discuss the more details and understanding in general, okay, about the blowout and blow-in fracture. So I'll be differentiating each categories one by one. So general understanding, please note that the blowout fractures are more common. So that in itself is a question which is more common, blowout fractures. Okay, now, and it is due to less severe injury. It is not due to a very severe injury, less severe injury. Whereas if you come to blow-in fracture, you will say that it is less common. So blowout is more common, blow-in is less common, and it is due to more severe injury, understandably. More severe injury of orbit is less common. As a result, blow-in fractures are less common. So this is just general understanding. Now, note over, what are the walls affected? Now, this is what I was talking about. The walls affected in blowout and blow-in fractures. Okay, so in blowout fracture, as I've told you, there will be involvement of floor, medial wall, lateral wall. Floor, medial wall, lateral wall. Okay, if you come to the picture, same thing. Okay, I'm not describing, I'll come to that later on. Okay, now, blow-in fracture. can affect any of these walls. That is a very important differentiating feature. Blow-in fracture can be affecting the medial wall, lateral wall, floor, wherever. Very commonly floor is involved in blow-in. But what makes a difference? Yeah, two structures, as I've told you, orbital rim and the roof. Okay, so means to say that if there is a floor, okay, floor of the orbital fracture with the rim, it is a blow-in fracture. Okay, if rim is not involved, then it is a blowout fracture. This is a very important, differentiating feature. Okay, now I'll come to the direction and impact. Now this is very important to understand the blowout and blow-in fractures. Now, what about blowout fracture? What is the direction of impact out there? Okay, now, okay, just zoom a little bit inside. Okay, now when blowout fracture, object is larger than the orbit. Okay, the object which is coming and hitting, which is larger than the orbital opening. Exactly opposite happens with your blow-in fracture. I'll come to that. And second thing is, and it's directly on the globe, whereas in your blow-in fracture, it hits directly on the rim. So rim fractures. Whereas in your blowout fracture, you have got it is sitting directly on the globe here. Okay, so now what happens? So that is very, very important to understand. Okay. And this, okay, let's understand. Now, before that, okay, I'll do one thing. Before that, I'll make you understand what happens in blowout. The exactly opposite, as I've told you. It's a high energy impact, more severe injury, we said, whereas the blowout is less severe injury. Now, what happens here is, it hits on the orbital rim, whereas this one is a larger object, the blowout hits on the globe. The blow end is a smaller object, okay, which you can call it as, okay, high energy impact, which is projectiles, gunshots, high energy, okay, gunshots, or even blunt object which can directly hit on your rim. Okay, blunt object hitting on your whole orbit, then it can result in blowout. If it is hitting directly on the rim, it can result in a blow-in fracture, but majorly it is a high energy impact when it comes to your blow-in. Okay, now let's understand this blowout fracture in detail. What happens when a large object, larger than the orbital opening, directly hits the globe. Okay, so now I'll show you the image out there. Okay, now see the image. I'll show you the image. So this is the object which is hitting, which is larger. You can see very clearly it's larger than the orbit, isn't it? And it is hitting directly on the globe. So the mechanics is different. Whereas this one is hitting on the rim. Okay, so this is hitting on the rim and it is fracturing the rim. So here it's not very clearly shown that rim is fractured. Both the cases, the floor is fractured. But then, yeah, there's a mechanics different. I'll show you that. But now understand this particular difference. Okay, now let's come on to the orbital blowout fracture in a little bit of details which you have to understand. So now we said what happens when it directly hits on the globe. So here, if this increases the intra-orbital pressure, the pressure inside the orbit increases, okay, because something is coming and hitting. So it is moving, the pressure increases. Now what? What next? Now, fracture of the most prone wall. Now, I didn't say most weakest wall or the thinnest wall, most prone wall. So this is what I'm going to come to when I'll be discussing incidence of fracture. The most prone wall to fracture is the floor. The weakest wall is the medial wall. Weakest and thinnest is the medial wall. But whereas the most prone wall is your floor of the orbital. I'll discuss with you this one later on. Okay, so fracture of the most prone wall. Why is it happening like this? Now, hit is there, the pressure increase. Now, pressure has to be relieved somewhere. Okay, now I'll just come back to this picture. So this is the hit. Pressure is increasing. This pressure has to be relieved somewhere. What happens? The pressure is relieved to the most prone wall to fracture. Downwards, the floor fractures. Okay, the floor fractures. So what is the most prone wall to fracture? As I've told you, the orbital floor. Okay, now what happens once a floor is fractured? The prolapse of the contents of the orbit into the maxillary sinus. Okay, the floor is fractured, the contents will be moving on to the maxillary sinus. Now what? Actually the volume increased. Okay, now you have, so because you don't have the floor of the orbit there, the volume is now the entire volume of the orbital contents where it also includes the maxillary sinus. This is a very important differentiating factor between blowout and blow in. In blow in the volume decreases. I'll show you why. So this is what is very important, that the goes in. Okay, it goes in, the volume increases. Okay, now as the volume is increased, okay, as the volume is increased, now the problem occurs accordingly. Let's come to that. Okay, so now as I've told you, there is an increase in volume because now the content is of the orbit is more into the sinus also, so it's a bigger volume. Now this is a very important feature to diagnose your orbital fracture from through a radiograph. I'll show you that. Okay, now so increase in orbital volume. So now what? Enophthalmos. You can see this picture there. Okay, the content goes inside, backward and downward. Okay, the content goes backward and downward. As a result, the eye goes, or the globe goes inwards because there is more volume for the eye to move inward and backward. So now there is enophthalmos. Okay, now if you just see this picture, okay, this picture, okay, we have studied about trigeminal nerve in anatomy. We have studied its branches. Now from the branches of the trigeminal nerve, you have got your maxillary nerve coming out, which is going through the floor of the orbit to become the infraorbital nerve. That is where you are injecting your LA solution for infraorbital block. So now it is going through the floor of the orbit. Your orbital floor is fractured. Okay, the orbital floor is fractured. It can damage which nerve? Infraorbital nerve. Now you know that when you give an injection to infraorbital nerve or block infraorbital nerve, you get the paresthesia. So this is what is happening in the blowout fracture. Please note, it is completely different when it comes to your blow-in fracture, the nerve damage. So two very important features, enophthalmos and infraorbital nerve damage, okay, leading to paresthesia. Now the mechanics is going to change now. We said in the blow-in fracture, hits on the rim, fracture of the rim. Okay, hits on the rim, fracture of the rim. Coming back to our older picture which we discussed, okay, what happens in your blow-in fracture is it hits directly on the rim and the rim is fracturing. Now what happens here is an inward buckling rather than fracturing downwards. The inward buckling happens because orbital rim is a very important supporting structure which is fractured. Now it has to go, it will go back. It will go back. So now fracture of the rim happens and the bone fragments is displaced backwards and inwards. Okay, the bone fragments are displaced backward and inward. One more thing I just want to show you. In your blowout fracture, see the content, it is going downward. Okay, the content of the orbit is going downwards. Whereas this one, it is going upward. The volume is going to decrease. I'm going to show you that. Okay, it is going upward and outward. Okay, see the globe, it was moving outward. So now, because there is no space, okay, though there is a fracture of the rim, though there is a fracture, even in the case like there is a fracture of the floor of the orbit, the rim is moved backward, so that opening into the sinus hasn't happened. So the volume is going to decrease. So means to say the bone fragments displaced backwards. Now what? Decrease in the orbital volume, as I've told you, because now it has gone back. Okay, it has not opened up the sinus, though a little bit as you can see here, but then overall your entire this area goes back. Okay, so now the volume has decreased compared to your blowout fracture. It's a very important feature to note. Now, due to this, lots of problems are going to happen. That's what we're going to see one by one. Rupture of the globe in itself, because no space for the globe. So where is going to be this pressure? Again, pressure is going to increase. Where is this pressure going to go? It can simply rupture the globe. Okay, your eyeball. Okay, which in itself can lead to blindness. Now, it can lead to proptosis, exactly opposite of enophthalmos, or it is similar to exophthalmos. Now, what exactly exophthalmos is representing is in your goiter, your eyes coming down. Same thing if it is happening in trauma, you call it as proptosis. That is the protrusion of your eyeball. This is the picture out there. Okay, your eyeball, okay, you can see very clearly the left eye of the patient is protruded outward. Okay, that's a protrusion, that's called a proptosis. Now, optic nerve injury. Now, this is important. Two things: optic nerve injury and superior orbital fissure syndrome. Now, this is important to understand or your anatomy. Again, we have discussed this anatomy. We have discussed the structures passing through it. Everything has been discussed, so I'm not coming to that. Okay, but then I'll show you what is happening and why it is happening. Your rim is going backward, isn't it? And the globe is going to hit on to two very important structure, which is the superior orbital fissure, okay, and optic foramen. So if it is hitting that, like even including the bone fragments also going back, it can damage your nerves passing through superior orbital fissure, causing superior orbital fissure syndrome. I'll come to the nerves, and also through the optic foramen. Okay, so let us quickly, okay, I've discussed this in detail in anatomy. Okay, we've just quickly see what superior orbital fissure transmits. Okay, we have discussed this laterally what it transmits and medially what it. Okay, I'm not showing the picture here. Just a quick review. LFT was what we learned about laterally, and medially was NOVA. So L is lacrimal nerve, F is frontal nerve. Both of this way we studied that it's a branch of ophthalmic division of trigeminal nerve. Okay, I'm going very fast just because we have discussed this in detail. Okay, then we have got trochlear nerve. So please understand that superior orbital fissure syndrome will have all the problems associated with damage of these nerves, which we have discussed already in anatomy. So then superior ophthalmic vein is there, okay, or I would say I'll show you this last. Okay, so that was it. Nasociliary, another branch of ophthalmic division. Okay, so all the three branches: lacrimal, frontal, nasociliary. Then you have got O for oculomotor, third nerve, A for abducens. Then 2 plus, one laterally, which is plus is superior ophthalmic vein, and one medially, which is plus is inferior ophthalmic vein. So why I've reviewed this is just to make you understand that superior orbital fissure syndrome, if at all it asks, it applies all the clinical features which causes the damage of trigeminal ophthalmic division, your abducens nerve, your trochlear nerve, your oculomotor nerve. So this in itself will be a big lecture which we have discussed. Hope you remember the clinical application or clinical problems associated with the damage of the nerve, which we have already discussed. So what you need to know here is what is a feature. One is very important feature, differentiating feature. So I'll just come to that. What is happening? Major difference to note here. Change in the orbital volume is different for your blowout and blow in, isn't it? So in blowout fracture, what did we see? We saw that there is an increase in volume. In blow in, we saw there is a decrease in volume, isn't it? So due to increase in volume, we saw inophthalmos in blowout, and due to decrease in volume, we saw proptosis in your blow in. That's very important. Now nerve damage also a major difference we saw. Okay, that is in blowout fracture there is an intraorbital nerve injury, whereas in blow in there is optic nerve injury, okay, and superior orbital fissure syndrome. Intraorbital nerve injury causes paresthesia, whereas optic nerve injury, blindness, besides your superior orbital fissure syndrome related symptoms. So that is about your basic comparison. Now, please note, diplopia happens in both. Okay, this is where your question can come. A patient had got hit on the globe or hit on the orbital rim, or maybe simply say that damage to the orbit or trauma to the orbit, and they will say diplopia with intraorbital nerve injury, or they will say that diplopia with your optic nerve injury. Like that, they can confuse you. So please note, or the patient has got or inophthalmos, okay, or proptosis. So based on that, you should be able to differentiate the clinical questions. Now diplopia, though happens in both cases, you see that the cost is different, and definitely thus the treatment will also be differing. Okay, and the major purpose of anything you do with your orbital rim orbital fracture is to correct diplopia and correct the bone segments. Okay, and you know that correcting the bone segments nothing but bringing it back, but diplopia, it is very important that you correct the diplopia. So for that you should be knowing the cause of diplopia, correct the cause of diplopia, that's it. Okay, so we have discussed this diplopia, what are the tests for that, okay, isn't it, his chart, okay, all those we have discussed in detail, how to do it and all, but here I'll just review it and I'll give you more additional points on this, what you have to know. Okay, so let's see what all we need to know in case of your diplopia. One is definitely the causes which are different in blowout and blow-in. Again, a quick review of diagnosis, and very, very, very importantly, when to go for surgical intervention, which in itself is a question. Okay, so let's discuss one by one. Okay, so before that, I'll just close this so that it doesn't interfere. Okay, now blowout fracture, what are the causes? Okay, what are the causes where you see the blowout fracture, or where do you see the or what are the causes related? Definitely, one is entrapment of extraocular muscle. We saw in blowout, the content of orbit is going into the sinus. So that can itself cause an entrapment of the muscles in between the sinus walls, I would say the floor of the orbit. Okay, whereas your blow-in, it is buckling backwards. So that is going to cause another problem. And second is edema or hemorrhage. Definitely, it's a fracture. There's going to be inflammation, there's going to be edema, and there's going to be hemorrhage. So due to entrapment of the extraocular muscles, what you see is, so what are the extraocular muscles? We studied, which is getting damaged and causing diplopia. One is inferior rectus and inferior oblique, anatomy again. Okay, I'm not repeating them. And entrapment can cause the movement of these muscles being affected. Okay, then edema interfere with the muscle movement. One is causing the entrapment, the other is hemorrhage and edema. But basically what is happening in both the cases is your inferior rectus and inferior oblique is not able to move. Okay, very simple. Now, whereas if you see the blowout fracture, it is due to blow-in fracture. Okay, it is due to direct trauma to the muscles, whereas the other one was entrapment. This is direct trauma to the muscles. Okay, or due to decreased orbital volume. We said there is decreased volume. So again, the muscles can't move. So in the first case, it was entrapped into the sinus. Here in the second case, it is a kind of volume decrease which is preventing the movement. And one is definitely direct trauma. So decreased orbital volume can cause what? Increased pressure. Okay, and which can compress the muscles. Okay, volume is decreasing, it is compressing, isn't it? And second thing is direct trauma. So it is hitting direct trauma, direct injury of the same muscles, inferior rectus, inferior oblique. Okay, and yeah, so means to say that one is a kind of the first one, blowout, is a kind of an entrapment. Okay, or preventing the movement. The second one is direct trauma. This is a major thing which you have to keep in your mind. Okay, so accordingly you have to correct and make your changes. Entrapment, clear the entrapment. Damage, no big problem. Okay, how much is the damage has to be analyzed and treated. Now, diagnosis. No, please note, when there is a blow-in fracture, it involves a cranial base. I'll come to that. Okay, so that is a more dangerous thing. So diagnosis of diplopia, lots of tests are there, but I need you to keep in mind two tests which we have already discussed. Okay, two tests are very, very important. One is forced duction test and the second is Hess chart. Okay, Hess chart. Now, basically, both are done for two different purposes. Forced duction test is to check the cause of diplopia. Is it due to hemorrhage? Is it due to entrapment? Is it due to injury? Is it temporary? Is it permanent? Okay, so that is forced duction test. Whereas Hess chart is to check for the degree of diplopia, how severe it is and is it improving or not. So this is again a question in itself. Forced duction test for cause and Hess chart, degree and improvement. Okay, so that is very, very important. Now, diplopia, most of the time it is temporary, it is fine, but then if it is permanent, you have to go for surgical intervention. So what tells you that it is going to be permanent or it is going to be dangerous? Okay, one thing is, I'll come to that for the third point, fracture greater than 50% of orbital floor. Now, this is a very problematic area. How do you know that greater than 50% of the wall is fractured? Basically, the first two. Okay, diplopia and inophthalmos, which is very severe. And how do you know that it is very severe? So, because you can't, unless you surgically open it, you don't know if it is greater than 50% fractured or not. So, that is a kind of a theoretical. More practical is, if there is a non-resolving diplopia even after 2 to 3 weeks of injury, even after 2 to 3 weeks of injury, still there is diplopia. Okay, then it means greater than 50% of the orbital floor is fractured, or it's a more kind of severe injury. Okay, second is inophthalmos. Okay, inophthalmos. So basically, two book says in two different ways, and I want you to follow the Fonseca, which says greater than 2 mm of inophthalmos. Okay, I going inside greater than 2 mm, which is very small amount. Peterson says 3 mm, but keep in mind it is a 2 mm, which is better to know. And yeah, that is how you know that there is a fracture of greater than 50% of the orbit. Now radiology. Now this is a very important point to note. Okay, radiologically, how can you differentiate the blowout and blow-in? Okay, very important sign of blowout fracture. You have heard of this multiple times. Hanging drop, appearance or trap door sign. So basically, if I come to this, okay, this is a picture of the first one showing the blowout fracture, second one showing the blow-in fracture. Now before going on to anything else, how to differentiate radiographically your blow-in and blowout fracture? How do you know that? Okay, that's very important for you to differentiate that. So if in case your blowout fracture, please note, if it's a blowout fracture, your orbital volume increases, isn't it? So you can see that, okay, bigger. So this is the normal orbit, you can call it as. This is the volume increase orbit where even you are, okay, the entire, it is not compressed. Okay, whereas if you see this picture, okay, you will see that the volume is decreased, it's a compressed. Okay, even your roof has fractured, your rim has fractured. Now see, this particular view, you will say me that so rim is fractured here. No, basically, see, if you're into a clinical practice of maxillofacial surgery and trauma, you get different sections, isn't it? Different sections of your, okay, different slices of your orbit. So this is kind of a posterior slice, okay, beyond the rim. So that is why you are seeing this. But basically, when we diagnose the patients with it, we get more slices, okay, and you get the anterior slice. So it becomes more easy to diagnose if the rim is fractured or not. But as a NEET MDS aspirant, you will not get multiple slices. So the easiest way to differentiate is your what? Size of the orbit. Okay, the volume of the orbit increased, this is decreased. Okay, that is always be there. But now if you're getting a slice which is beyond your orbit, you will see that there is no orbital rim like here. Okay, or if you're getting it like, here you can see there is a fracture there. But more importantly, it is this. So trap door means, or hanging drop means your content gets hanged into the sinus. This is called a hanging drop sign. Okay, or your trap door appearance. So it's not very clear here. Anyway, the trap door means the maxillary sinus, or the floor of the orbit of or the roof of the sinus. Both are the same, isn't it? It is trapping the muscle. So it's a trap door. It acts as a trap door. So this is basically how, majorly I want you to learn this. Okay, how to differentiate between your blowout and blow-in radiographically. Now let's come to the orbital roof fracture. Now, very important because it happens in the blow-in fracture and it is causing lots of problems associated. Let's discuss that. So as you know, in blowout fracture, there is no roof fracture. Orbital roof fracture is not there. Whereas in blow-in fracture, you see the orbital roof being fracturing. Okay. Now see what are the features you have to know. Before that, we've discussed in anatomy the layers of meninges. I'll just review it here for the purpose of understanding this roof fracture better. Okay. It's very important. Now, so the layers of the meninges from outward to inward. From the outward to inward, I'll show you the image. Okay. For you to understand it better. We've got dura mater, which is the outermost, and leptomeninges, okay, which is the other two. The combination of pia and arachnoid is called, or arachnoid and pia is called the leptomeninges. Okay, the both together. So arachnoid and pia is the leptomeninges, and dura mater, which is the outermost. Okay, I'll just give you an understanding here, where dura mater is nothing but it directly adherent to the inner surface of your skull. I'll show you the image very soon. Whereas the pia is the innermost, which adheres to the surface of the brain. Okay, now this is very important to understand. Okay, I'll just come to the image for you to understand this better. So as we told you, if you see this image, this is a roof of the orbit. If this fractures, okay, that is what we are talking about. Now we said the inner surface of your skull. Okay, means it will be here, inner surface of skull. Okay, you've got pia mater. Sorry, you have got dura mater. Okay, now please note, this is where people make mistake. It goes inside like this, isn't it? It is also here, also it is there. Okay, here also it is dura mater, dura mater, dura mater. It goes up, dura mater. People think dura, arachnoid, pia, and this in pia is here. No. Okay, so dura is the entire here like this. In the center you have got your arachnoid. In the inner, closer to the brain, you have got the your pia mater. Okay, so now why am I talking about? I'll tell you why. You have to know that there is a dura mater here. Okay, that's very important to understand this. Okay, and that's the only purpose of me to bring this out, this discussion out for you to understand. Okay, so yes, just decrease this. Okay, so as a result, now when there is a roof fracture and when there is meninges involved in the roof, especially the dura mater, you've got three related complications which you have to be aware of. The first one is the, please note, okay, just please note, it's a base of skull fracture. Okay, you see the picture, this is the skull base, isn't it? This is a part of a skull base. No doubt, no? This is part of skull base. So it's a skull of the base of the skull fracture. Okay, and yeah, here what you can see is a CSF leaks out. Okay, CSF leaks out through the fracture line because it's the base of the skull, and also there is an intracranial hemorrhage. Okay, CSF leak and intracranial hemorrhage. Now you know that where is CSF present? Anatomy. Okay, the subarachnoid space. Where is it? Subarachnoid space is in the between arachnoid and pia mater. We have discussed this in anatomy. So there is CSF leak. Okay, understandably. Now, more importantly, or you have to keep this one very much in mind, there is adherence of dura mater with the orbit. I told you, coming back to the same picture here, this is the orbit. I told you there is a dura mater here, inner part of the skull. So now this, when there is no roof, the dura mater above and the contents of the orbit adheres. What is the problem with that? Okay, there's a typical term to know. There's a pulsation of the brain because dura mater is attached to the brain. Okay, dura, arachnoid, pia. So it is attached to the brain. So the pulsations of the brain, any blood vessel, any pulsations of the brain is transmitted to the orbit directly because of the adherence. Okay, this is called pulsating exophthalmos. Now you're talking about blow-in fracture. Sorry, blow-in fracture. So blow-in fracture, you have got proptosis, which is same as like exophthalmos. Okay, I told you, typically exophthalmos we use in goiter. In trauma we use the proptosis. Okay, so pulsating proptosis or more here they're talking in textbooks of pulsating exophthalmos. Okay, pulsating exophthalmos. So that is the next problem. So we saw the two problems. One is CSF leak and intracranial hemorrhage, pulsating exophthalmos. Third point, herniation of leptomeninges into the orbit. Definitely, above dura there is your leptomeninges or your arachnoid and pia maters. Okay, so that comes into the orbit because the roof of the orbit is fractured. Okay, so now what? Further increase in the pressure in the orbit, which can further cause complications. So three things which you have to note here. Okay, this is again see, as the things are getting more and more complicated in exams, you have to know a little bit of clinical concepts here. What is happening in roof of fracture and why it is happening. Okay, I'm not taking a time. I know exams are coming very close. So now that is about your basic blowout, blow-in fractures comparison. Here I want you to also know that which is the most weakest wall. Always the doubts there. Weakest wall, most prone wall to fracture. So let's discuss, let's come to that. So the incidence of fracture says that, okay, we have got two very confusing area. Is it orbital floor more common or medial wall more common? Okay, so that is important to understand here. Okay, I'll just do one thing. I'll remove this. Okay, now orbital floor fracture is the most common. Okay, orbital floor fracture is more common, which is 60 to 70% of the cases. One reason, okay, I'll come to each reasons. Now, whereas medial wall is only 20%, but the medial wall is known as the thinnest and the weakest wall of the orbit. Okay, interesting, isn't it? Thinnest and the weakest wall is your, that's in itself as a question. Okay, some books say that weakest can't be medial wall because weakest means more prone to fracture. But then, yeah, we are learning for NEET MDS. Okay, when you take your oral surgery, go into the research of that. Anyway, for your purpose of entrance preparation, the weakest and thinnest wall is your medial wall. Now the question arises, why is orbital floor fracture more common? Okay, more common is not there, more common, even though it's not the weakest and the thinnest wall. That's a question every one of you will ask. Okay, so quick understanding. Okay, this is majorly for your Viva, okay, for final years. Three theories or three concepts there. One is hydraulic theory, the talk. Second is the bone thickness and structural support, and third is your direction of impact. So let's discuss one by one. The first thing, as I've told you, it's a hydraulic theory. Now, we know that there's a hydrostatic pressure which is within the globe. Hydrostatic means like water is there, heat is there, pressure increases. Okay, hydrostatic pressure increases within the globe, and this has to be transmitted to the orbital walls. That is one thing. So where will it transmit? It will transmit to the most prone wall, like I told you. Now, why? That's the next question. Then what decides the most prone wall? That is your bone thickness and structural support. Okay, so if you go, okay, one thing I missed out is thinnest wall of the orbit is your medial wall, and this is due to the lamina papyracea of ethmoid bone. I'll show you this, but I will also discuss with you the bone thickness and structural support. I'll show you both together. Okay, means to say the medial wall, if you see, okay, the medial wall, if you see, you'll see that it is supported by the sphenoid and ethmoid bone. Okay, and whereas the floor, it is supported only by maxillary sinus. Come to this picture. Okay, if you just see there, as I told you, this is the lamina papyracea of ethmoid bone. So you can see this is ethmoid bone, the orange color. Above it is the frontal bone. So this is the lamina papyracea of the ethmoid bone. And we saw that it is supported by the sphenoid and ethmoid. So it's very clear. This is the sphenoid, yellow. Okay, and it is ethmoid. Okay, a little bit of lacrimal bone, but now ethmoid is stronger enough. Your sphenoid is also strong enough inside. Okay, though the lamina papyracea is very thin, you've got stronger bone inside. It's a part of ethmoid. So, and more importantly, your sphenoid bone, it's strong enough. So, though it is the weakest wall, it has got a good support. Okay, weakest in the sense I would say thinnest wall. So it has got a good support inside. Whereas if you go down, okay, this is the maxilla and maxillary sinus. So you have got no support inside, simply air filled. Okay, very little support. So that's another reason. And finally, as you know, the direction of impact. Most common cause of orbital trauma is what? Object larger than your orbit. That is most common. Okay, and you don't see every day someone taking the gun and shooting people. No, more commonly you see that people fighting, or something goes and hits on the face, which is like this. Okay, ball very commonly. So it's as a result, the direction is the direction of force in a particular direction, that is downward and inward. Okay, downward and inward. So the floor fractures more commonly than your medial wall. So by that, I'll come to an end of this particular discussion. I hope, okay, this was a little elaborative discussion, but then, yeah, clinical questions can come based on this. So that's the only purpose or the only reason I went into so much of details. Okay, so that's it. Have a great day and take care.